This month, we're focusing on cardiology as it pertains to critical care transfers and stuff that we should probably know. So the first part is going to be about 5 particular EKG findings that really, as critical care medics, you have to know. And you have to consciously and intentionally look for, or you'll miss it. And then the second part is really a brief overview of Impella. Anyone transport those patients? A few of you? Balloon pump, you probably have a lot more of those. And then a quick review on transvenous pacing, how it's put in. Because if you don't know how or where they're placed, then you're not going to really be able to know what the complications are. So they wanted me to talk about those 3 things in particular: Impella, balloon pump, and transvenous pacers, not the transcutaneous ones. KO. And just like last time, this is way more fun if you're interactive. I don't want to be talking at you for 3 hours, so please. Particularly Ashley and Erica, who've been up all night, I'm going to ask them all the questions so that they stay awake. So, okay. So, because we're going to be looking at a lot of 12 leads in the next hour, I wanted to kind of get your blood flowing and talk about a particular EKG case. So our EKG minute is as follows. You have a 77-year-old male who calls 911 for acute chest pain. He was admitted a week ago for STEMI. He's since been home. And so now this is more of a kind of an acute call. So here is what his 12 lead looks like. Take a gander at that. Hopefully the screen is big enough that you can see. Now, when I ask you to look at a 12 lead, I always say no matter what it looks like, no matter how dramatic it looks like, no matter how normal it looks like, always do the 5 things. And you have to do it in this order: rate, rhythm, axis, intervals, then your patterns. Especially when it's really dramatic, people tend to jump right to patterns, right? So coming up in a couple months, all the med students become doctors and interns at the hospital, right? In July 1st, that's not that far away. And when the first level 1 trauma comes in, they go straight to the open femur fracture, like, whoa, look at that, the bone's sticking out. I'm like, hey, they're not breathing. Let's do ABCs first, okay? Because they want to go right to that. And I tell you, a lot of new paramedics, they get a 12 lead, they see this big old STEMI, they say, wow, it's a STEMI, and they go right to that and start calling and say, wait, you haven't done rate, rhythm, axis, intervals. You haven't done any of that stuff yet. So if you do it the same way every time, you're going to be much less likely to miss something. I can't tell you how important this is because I'll see folks who are learning 12 lead for the first time, and most instructors will have some variation of this, and they'll get to, here's the rate, what's the rhythm, and they'll say AFib. And I say, well, how did you get to that? Well, we're just supposed to know what that looks like, and that's a horrible way to teach 12 lead, in my opinion. You don't, so when I say rhythm, I don't mean, is it atrial fib, is it VTAC, is it normal? That's not what I mean. I mean, is it regular? Is it irregularly irregular? Or is it regularly irregular? That's what I mean when I say what's the rhythm. So give me an example of a regular rhythm. Normal size rhythm, okay? How about irregularly irregular? AFib, right? Almost 95% of the time, atrial fib. But that other 5% of the time, it could be what besides AFib? What? No, it's still irregularly irregular. That would be, well, yeah, I guess that's not a wrong answer. VFib is irregular, regular, and torsades, but hopefully you know that. There is, I'll give you a clue. There are some P waves, but they all look different. WAP? Wandering atrial pacemaker. Can we say that? It's wandering atrial pacemaker. But if WAP is more than 100, what do you call it? It says 105.
Fast WAP.
Fast WAP. You can't say it. No. MAT, multifocal atrial tachycardia. Remember that, MAT? So wandering atrial pacemaker, or MAT if it's more than 100, is typically irregular. And if you don't look carefully, you can misdiagnose it as, oh, it's irregular, that's AFib. But that's, again, why you do it in this order, because once you get to intervals, you should catch your mistake, because wait, there's P waves and PR, that means it can't be AFib. So how is this irregular, but there's a PR interval? You would then back up and say, wait a minute, self, this can't be AFib, there's P waves here. And then you look real closely at the P waves, they're all different. Right? So, well, this is MAT, or this is WAP, something else, but that's not AFib, because that's how you catch it. And then what is an example of regularly irregular? Bigeminy, perfect. Trigeminy, quadrigeminy. It's regularly irregular. Okay, that's the perfect example of something that's regularly irregular. So, okay, so that's what I mean by rhythm. Is it regular, is it irregularly irregular, or regularly irregular? Third is axis, and we'll talk about how poor man's way to determine axis and why that matters. Intervals, PR, QRS, QT intervals, R to R intervals, all those things. And then finally, now you can look at patterns, okay? So let's apply this, because we're going to do this for the 12 leads we're looking at from this point forward. And hopefully, if you like it, I hope you like it, you'll do it in your own practice of medicine the next time you run a 12 lead on a call, you'll apply this. I think it's going to be much more systematic and much easier for you, I think, to approach a 12 lead. So let's look at this again. This is a guy who has a history of a STEMI, and so what is the rate? What is the easiest way to determine heart rate? It's not a trick question. Look at the number. Look at the monitor. It says what the heart rate is. But I'll tell you, I always verify, because there are times when the monitor gets it wrong. Can you think of some times when that might happen? Like, what does the monitor usually check? Or what is it counting? The QRSs, R to R intervals, right? Have you ever seen hyperacute T wave so tall it's taller than the QRS, and the monitor counts both? I've seen that. Not very often. I've seen it once or twice, where it's like, the heart rate's not 120. And it's like, no, it's counting the Q and the T. So the heart rate's about 60, but it's hyperacute T, so it's counting twice. So I always look at the R to R interval. You have, if you find a QRS right on the line, like right here, it's right on the line, and you count big boxes to the next R wave. Remember how to do it? 300, 150, 100, 75, 60. So it's between 75 and 60, closer to 75. So you want to call it, 70, that's fine. Close enough, right? We just want to know if it's fast or slow. And again, why does that trick work? What is the basis for using that little trick? It's because the speed. So whenever you see an EKG that looks a little weird, whenever I do, the first thing I do is make sure I check calibration. And I look, this is in fact 25 millimeters per second. So if it's 25 millimeters per second, I know that 5 boxes is 1 second on paper, time, right? That makes sense? So now if the R to R interval is 5 big boxes, that has to be 1 per second. That gives me a heart rate of 60. See how that works? So that's how we back calculate. Okay? And I know that the standard deviation is 10 millimeters per millivolt. So I should see at the beginning of my strip this square wave. You ever wonder what that square wave is at the beginning? That tells you you're at full standard. So when would you ever ask your EKG to go to half standard, where it's only 5 millimeters tall instead of 10? Maybe if you want to shorten it. But maybe they've got severe LVH and the QRSs are running off the page. You just kind of want to shorten it, just kind of get it all on one page. Okay. Why would you speed it up to 50 millimeters per second? Well, not millivolts, but speed. Like maybe they're so bradycardic, you're just trying to capture no, actually the opposite. They're so fast. You want to speed up the paper so that you can look in between them more. Is there a P wave there? I'm not sure. You can speed up the paper to see if you can catch a P wave in between there because it's going so fast. It's so compressed. What you're trying to do is lengthen time on paper. So you would speed it up. You would slow it down if they're so bradycardic, you're only getting 2 QRS complexes on a strip. You want to get more on a strip, you slow it down a little bit. So that's why you would do that. People rarely do it, but one of the habits I make, because if it's there, it can happen, right? I just do a quick glance, make sure I'm at full standard, and I'm at 25 millimeters per second. Okay? So that's the rate. What comes next? Rhythm. Does this look regular, irregularly irregular, or regularly irregular? It looks pretty regular to me. How about the axis? What's the poor man's way of axis? I mean, the machine can tell you, but also you should verify. I like to do it really quickly. Remember the thumb up. There's an even easier way to do that, looking at just lead 1 and lead AVF. So if lead 1 is positive and AVF is positive, I got 2 thumbs up. That's a normal axis, ballpark. If lead 1 is positive and AVF is negative, that's a left axis deviation. Opposite is a right axis deviation. 2 thumbs down is called a
Extreme right.
Yeah, some books will say extreme right. I've come to adopt the other term, which is indeterminate axis, because it really is no man's land. I mean, maybe it's extreme right axis, maybe it more accurately from an EP standpoint is probably just indeterminate axis. Okay, so yeah. So in this case, what's the axis? 1 is up, AVF is down. Yeah, I would say it's a left axis deviation. Okay. That might play a role in diagnoses, but people always ask me, why would I want to know axis? Like, what difference does it make? Well, not a ton sometimes, but it's helpful. For example, if someone is having what you think is an acute coronary syndrome and they have a nonspecific EKG, but they have a left axis, maybe some LVH on there, and the patient's like, do you think I really need to go to the hospital? I mean, is there anything abnormal with my EKG? Do I have any, my heart looks normal? You can honestly tell them, well, you've had high blood pressure your whole life. You never take your medicine. That's a risk factor for heart attacks. You're having chest pain. That's why we're here. And you've got the whole axis of your heart has changed. Your heart morphology, your muscles are hypertrophying. That's why it looks like this. And yeah, you've got some risk factor. You should go to the hospital. That helps. Or if it's a young lady who smokes, is on birth control pills or other estrogens, and they're short of breath, a little tachycardic, and a little pleuritic chest pain, and they have a right axis deviation. Maybe you're worried about a fairly large PE, because that right ventricle is working a little harder than it should, and maybe more electrical vectors are going through that. And you can say, hey, actually, I think you might have a clot in your lungs. So little things like that might help you build a case for going to a thrombectomy-capable hospital versus not, for example. You can justify that in your narrative, I think. So these are just a couple of reasons why axis sometimes plays a role. So rate, rhythm, axis. How about intervals? PR intervals, QRS, QT intervals. Do they look relatively normal? PR should be about what? 0.12 to 0.2, good. Y'all critical care, don't be shy, yell it out. Okay, how about QRS complexes? When? Left lung, good. And QT, what is the eyeball rule for the QT intervals? Yeah, the numbers are fine, but I mean, if you're just eyeballing it. The QT should not be more than half the R to R interval. So if the R to R is 5 big boxes, the QT shouldn't be more than 2.5. Okay. Again, it's a ER doc's way of just eyeballing stuff, right? I'm not a cardiologist, so I just want ballpark figures. So to me, it's not a wide complex. The PRs look normal. The QTs don't look long. Okay, R to R is not Brady or tacky. It's normal. So I would say that those are normal looking intervals. Okay, so now the fun part. Now we get to see things like, well, what pattern do I see here? Now we're looking for things like, is there ST elevation? Is there ST depression, T wave inversion, hyperkalemic changes? Is there ST depression? Is there weird patterns that you would recognize as a specific diagnosis? Do I see Welland syndrome? Do I see De Winter's T waves? What other patterns do I see? Do you see anything on there that would be concerning?
ST elevation.
Okay, where do you see ST elevation?
E3 and AVF.
3 and AVF definitely do not look normal. I agree. Can we say is it an obvious ST elevation? So is the ST segment above the isoelectric line in 3 and AVF, like obviously? I don't know that it's obvious, but there is definitely something about 3 and AVF that is not normal. And sometimes the better part of valor is just simply recognizing when something's not normal, right? So if I could convince you that lead 2 also has similar morphologies to 3 and AVF, it kind of reminds you of a tombstone. The shape of a tombstone. You see that now? Have you ever heard someone say they have tombstoning? Okay, all right. So that's what they mean when they say this patient has not a clear ST elevation MI, but they've got some tombstoning and doesn't look really good. And when you see tombstoning in a contiguous lead like 2, 3, and AVF, you gotta wonder, are there any other changes anywhere else? And sure enough, you also see in the green circles, what would we call that in the green circles? A reciprocal changes, right? ST depression. So the reciprocal of 2, 3 AVF is 1 and AVL, and sure enough, you see some ST depression in 1 and AVL. So kind of like what some people might call a STEMI equivalent. That's what I would be very worried about. And you look at the lateral leads also in the precordium, V4, V5, V6 also shows not quite as pronounced the tombstoning, but it's getting there. You know, it's of concern anyway. But I think at the very least, you can say, wow, that looks really, really concerning. So I think you could call the hospital and say, this guy looks like he's having a STEMI equivalent, acute inferolateral STEMI. Based on his history, his risk factors, he just got a STEMI last week. So now the big question is, would you activate a code STEMI?
Yeah, why not? He's presenting like it.
With his history, I would not at all blame you for saying, hey, this guy just had a STEMI last week, he's having chest pain, he looks bad. Tombstoning in 2, 3 and AVF with depression and 1 in AVL, I'm calling a code STEMI. And no one would fault you for that. So here's what actually happened. This is an actual case. So the patient arrived to the emergency department. Cardiology was at the bedside soon after. His repeat EKG now shows the tombstoning in 1 in AVL, which was interesting, with reciprocal changes inferiorly in 2, 3 AVF. So kind of like switched. You still had what I think looked worsening changes in V5 and V6. And so luckily, the cardiologist who met the crew in the ER knew the patient from last week. Said, I know this guy, and he has horrible coronary artery disease. It's too extensive for the cath lab, is what he said. So the patient got aspirin, the patient got heparin, the patient got Plavix, antiplatelet agent. What is the generic name for Plavix? Clopidogrel, very good. got nitro, and got medical. He did go to the ICU, to CCU, but he was too unstable, and his coronary artery disease was too extensive to go to the cath lab. Probably explains why his EKG was changing like that, because at one point in time it was mostly reflected inferiorly, then now it was laterally, but still it was bad. Okay, he was not a candidate. So here's what happened. He continued to have very mild chest pain in the CCU. He rated it as a 0.5 out of 10 for most of his stay. He stayed on the telemetry unit, and how would you like to have these people's jobs? Have you ever seen a telemetry monitor? Their job is literally to stare at the screens and just watch for alarms, and they're the ones who call the nurse's station and say, hey, so-and-so is changing, or so-and-so is having weird dysrhythmias or something. Anyway, a very important job, but boy, I don't know if I could do that for hours on end. Anyway, they maintained the nitro drips, they maintained the heparin drips. His troponin levels did begin to taper down, and he eventually was transferred to the telemetry unit the following day and was discharged to home on day number 4, stable condition. But they did put him on long-acting nitrates. So, ever hear of IMDR before? You've probably seen that on people's med list before. IMDR is isosorbide mononitrate, which is an extended release version, 30 milligrams a day of this extended release nitrate. What it aims to do is try to maintain some measure of vasodilation chronically, just because his disease was too extensive to do anything percutaneously. Just try to keep his blood vessels open as much as you can. By the way, can you give somebody who's on IMDR nitroglycerin acutely if they're having chest pain? Yes, actually you can. You absolutely can. So you feel warmed up now? Yeah, got the juices going? You awake, you too? Okay, good. Any questions on that one? All right, so now that you got your brain going and you're warmed up a little bit, let's look at 5 cannot miss EKGs. The issue with EKG tracings, much like the issue for radiologists, is if you make a mistake, if you miss a fracture on an X-ray or a head bleed on a head CT, it's there forever still, right? It's there, you missed it, there's no denying it. Same with a 12 lead. You can say, well, I didn't hear a murmur at the time or whatever, but you can't say I didn't see the STEMI on the 12 lead because it's right there forever. So you really cannot miss these. We're going to look at 5, and we're going to go kind of high speed. So you ready? Okay, case number 1. A 32-year-old female with no real past medical history fainted at the local grocery store. She said she had felt some palpitations earlier, but just said, I had an extra cup of coffee earlier, and so maybe that's why. The EKG shows nothing that looks super remarkable off the bat. But of course, all of you are experts now at doing the 5 things. So what is the rate? I even helped you out with showing you an arrow where to start, because it's right on the line. Yes, I heard someone say it. Very good. You looked at the number, 59. You're absolutely right. So let's verify it. 300, 150, 175, 60, just past 60. So yeah, 59 is good. The machine says it's 59. So I'll take 59 for a rate. What's the rhythm? Regular, irregularly irregular, or regularly irregular? Regular. It's regular. Okay, what is the axis? It's a normal axis. 1 is up, AVF is up. Rate, rhythm, axis. Okay, what is the intervals? PR, QRS, QT intervals, R to R intervals? Let's just start with the easy one, QRS. Is it Y complex or looks pretty narrow complex? Okay. How about How about PR intervals? PR. I'm hearing people say normal. QT intervals. So just, I'll give you a clue. Just remember, what is the history? Syncope and palpitations, okay? So I don't know if that helps you at all, but look closer at some of your intervals. What is one that should catch your eye? And if you miss it, it'll be there for all to see that you missed it. I hear QT. I hear P. I hear someone says the QRS looks funny. The P, so what?
So it's the ventures, it's, I'm in class now.
Oh, you should know this
I know,
then.
that's what I'm saying, I know, it's not the ventures, it's,
Well, you're on the right track.
I know.
What is it about the P wave or
P.
which interval are you talking about?
PR.
What
Very
about the
close.
PR?
It's very short.
Okay, there you go. Okay, so I don't know if you heard her, but she says to her, it looks like the PR interval is very short. Okay, and I would say that she's right. If you look really close at the PR interval, there should be a gap there of 0.12 to 0.2, right? But if you look at the P wave, almost immediately it starts to, and here there is almost no gap in between there. It's pretty short. In fact, it kind of has a scoop to it.
Yes, it's, I can't remember the name of it.
You can't. Oh, hey, you think it's what?
WPW.
Yes.
I think you're right. So this is a sinus bradycardia with WPW is what this is.
No. What the heck?
What? Tell her what it stands for.
Oh, I know that, Wolff-Parkinson-White.
Wolff
What's the name of
Parkinson.
that? The
That is a
delta wave. That's
delta wave.
Thank you. I couldn't put the name to it.
I promise I didn't plant her. That was exactly a perfect segue. That is called what you're looking at is a delta wave. So you've heard me say this before, that the mind, the eye only sees what the brain knows, right? So you got to be very intentional. This is one of those things where you got to look for it. So that delta wave, you should have this gap, your PR, but when the P wave ends and almost immediately it scoops like that, that is your delta wave. The dotted lines represent, again, what it really should look like, but that red wave, the delta wave, is what your eye should kind of gravitate towards. You would only find that if you went through your steps, including intervals. You're like, wow, this interval is not 0.2 to 0.2. Actually, we're shorter than that. So you can see these delta waves in almost any lead. V2 is a really good one there that you can see as it's illustrated there. But WPW, can anyone tell me what causes that? What kind of a syndrome is WPW?
So isn't it have something to do with your AB and SA node?
Mm-hmm.
Between, they're like.
In between, there is a short circuit. Okay. For an ice cream cone, can anyone tell me what that short circuit is called?
Bad.
Okay, because I don't have an ice cream cone with me, so I'm glad no one got it. It is the accessory bundle of Kent. Oh yeah, that was right on the tip of your tongue, wasn't it? So the accessory bundle of Kent is this short circuit between the atria and the ventricle. What it does, it's a pre-excitation syndrome, okay? So before it fully repolarizes, the atria is starting to depolarize a smidge early, just milliseconds early, through this short circuit. And when that happens, you don't get that gap in your PR interval. It's pre-excited, so it tends to scoop a little bit early. The problem is that predisposes people to what? What dysrhythmia?
SVT.
SVT. Very good. So it predisposes people to SVT. So the palpitations she was feeling was probably paroxysmal SVT. So why did she faint? What happens to cardiac output at 220? Pretty low, right? So she just didn't have enough time to fill. Her heart rate exceeded the ability to maintain forward flow, and her cerebral perfusion pressure dropped. Mother Nature said, your brain needs blood, I'm going to put you on the ground, and that's what happened. Okay? So it put her on the ground, and she passed out. Now, there is another type of WPW. This is a type B. This one is a little bit more difficult to see, but you can see it in V1 and V2 because that PR interval is also very short, because that, instead of scooping up, it's scooping down because the QRS is down. That's all. Don't let it fake you out. A lot of people miss this because they're always looking for an upstroke delta wave. Well, you can see it upside down in a type B. So again, it's not about recognizing the delta wave as much as it is recognizing a short PR interval, and then you say to yourself, why is this so short? And then you make yourself look for the delta wave. Whether it's right side up or upside down, you're going to find it if and only if you look for it. But you got to be intentional about it. So in a type B WPW, the delta waves are predominantly negative in V1 through 3, predominantly positive, as you can see, in V4, 5, and 6. So you can see that because it makes it look like a wide complex, some people mistake it for a left bundle, but it's not. It's not a left bundle branch block. Okay? So just, again, make sure you look at it. The significance of WPW is that short-term morbidity is from the trauma from syncope and then smacking your head on the ground or something else on the way down. That's one of the short-term morbidities. The tachydysrhythmia itself, of course. But then long-term, there are consequences to it in that patients with WPW can develop congestive heart failure. They can develop atrial fib. Of course, the biggest problem is its mortality. There is a mortality risk with WPW in that they can get, with intense exercise or undiagnosed WPW, and then they decide to go to a spin class for the first time or play soccer or something else, all of a sudden they drop dead on the field. Why? Because their heart rate is so fast that you get this R on T phenomenon, similar to why we synchronize cardiovert these people, so we're not inadvertently trying to depolarize on a repolarization. So these folks can do R on T on themselves, and they go into VF, and that's game over. So game over is bad for young people, so we try not to do that. Okay, make sense? That's a good case. That's one of the 5 that you will see if you haven't already in your lifetime. Lots of SVTs. I'm sure all of you have treated SVTs, but you'll probably at least once or twice see an actual WPW. You might even be the one to diagnose it if you look for it. So just be sure. The one thing as a medical director that I fear is that you get an otherwise young, healthy person that faints in the grocery store. They're fine now. Their EKG looks fine. They say, I'm not injured. I just had a little too much coffee. I think I'm okay. And the medic does not recognize the life-threatening change. And they have them sign a refusal. Okay? That can kill them. So whenever you have a young person who passes out like that, this is one of the 5 things you just have to make yourself look at. Okay? All right, that was a good one. Ready for the second one? All right, here we go. Ready, player 1. 18-year-old passed out while running up and down the soccer field. He's now awake. He's alert. He feels fine. He doesn't want to really go anywhere. He wants to go back in the game. He just didn't drink enough water. The coach says, I'm sure he's fine. Can he go back in the game? Would you even bother getting a 12 lead? Besides the fact that we're sitting in a 12-lead class? Okay, good. I'm glad you would, because I would too. So here's his 12 lead. So it's going to take forever if we do the 5 things like formula. So just do it in your brain. So rate, rhythm, axis intervals, pattern. We'll do it real quick. Rate looks 300, 150, 175, 60. So it's not fast, it's not slow, it's about 60-ish. The rhythm looks pretty regular. Axis looks normal. Intervals. Here's where I'll pause a little bit. Anything in the intervals that look Now this, I think you should be able to eyeball. If you've seen enough normals, something should pop out in your brain on this one. Okay, what about the T wave? It's pretty, it's right next to the P wave. Is that normal? No. So how long did we say the R to R should be? The QT should be no more than half the R to R interval. So I'll try to make it easier for you here. I blew it up to be a little bit bigger, and I put a little scale there. So remember, the QT starts at the Q and ends at the end of your T wave. That's your interval that you're measuring. I put the little yardstick up there to show you that that smaller yardstick is half the distance of that R to R. So I put the yardstick at the beginning of the Q wave, and that T wave should end before this yardstick, does it? It's significantly past that. Right? So I would think that, man, that's what it should look like, half the distance of the R to R, at least no more than half the distance of the R to R. But if that extends past that, like we saw in our previous one, that's delayed. Okay, so you got to think, this is a long QT syndrome, perhaps. Okay. Now the other mistake that people make, because this is pretty easy to see, but sometimes the end of the T wave is not entirely evident. So there is one way that you can establish the end of the T wave. Does anyone know exactly how you're supposed to measure the end of the T wave? It's actually pretty simple. What you're supposed to do is take the maximum slope of the end of a T wave, which is that maroon line, create a dotted line where the isoelectric line would be, and then where the intersection of this maximum slope and isoelectric line is, you draw that little blue line. That's where the intersection of those two are, and that's the end of your T. So, for example, on that first QRS complex, you probably don't have to do that because it's pretty evident where that is. However, on the QT interval on the number 2, and certainly number 3, it may be a little bit more difficult to find out exactly where that is. And so doing that slope and the intersecting line is probably a little bit easier to find where's the end of my T wave so that I can calculate from the Q to that point. What is my QRS complex? So when you look at his, clearly from the Q where that gold arrow is to that intersection, it is well past the halfway mark of the R to R interval. And so what are you most worried about with this kid? That when the T is so close to that P wave, you're worried about R on T and you're worried about dysrhythmias. And for a lot of these high school kids that have dropped dead on the basketball court or soccer field, they had undiagnosed long QT syndrome, usually a congenital defect that no one ever had reason to get an EKG on them. And so they then participate in sports for the first time and down they go. So also, even though half the time the Marquette is correct only as the diagnosis, what it is fairly good at is the calculations, the intervals. So sometimes the 12-lead, well, not sometimes, all the time, you can look at the printout where it'll give you the QT corrected, QTC. And when you look at the QTC in milliseconds, this is some textbooks are just a little bit different, but for the most part, generally from 360 to about 450 for men, 370 to 460 for females. This is a normal QT interval. Above 390 for men and 400 for women, you have possible prolonged QT, but up to about those points, that range is relatively normal. Now you get something less than that, you're going to have short QT, but what we really worry about is anything above 450 milliseconds for men, 460 for females, and above, you worry about long QT. Now, when does long QT become long QT syndrome? Because you can have long QT, but if you're asymptomatic, do you have long QT syndrome? When they're symptomatic, they have to be symptomatic. Syndrome means a constellation of findings or symptoms that suggest a particular disease process. So if you don't have any symptoms, what you can say is they have long QT, but maybe they don't have the syndrome yet. But when you start having things like a family history of fainting, a personal history of syncope or fainting or near syncope, lightheadedness, palpitations, dizziness, now you're crossing into symptomatic thresholds, and now you can say, well, plus this finding, they have long QT syndrome, and they're at fair amount of risk that you have to consider. So again, increased risk of sudden cardiac death. There have been about 17 genes so far identified for congenital long QT. Here's the cool part. Since this has been recognized about 20-some years ago, a lot of your better high school athletic programs now mandate screening 12 leads for youth sports. This article in JAMA from 2006 showed a 90% reduction in sudden cardiac death when implementing something as simple as a 12-lead screening before sports. That's an amazing, amazing save, isn't it? I mean, it's not invasive, it's cheap, put it on, do a 12-lead, you're not dead now. I mean, that's amazing. So most modern high school sports and certainly collegiate sports will do screening 12 leads now for this very thing, because it's easy to see, you can save someone's life, clearly. So again, however, it's one of those things that if you don't look for it, you're not going to see it. So somebody faints, someone lightheaded, palpitations. This is the second of 5 things that you really ought to pay attention and specifically look for. Okay. All right. Ready for number 3? Fun? Good? Helpful? Okay, good. Case 3, a 63-year-old calls 911 for palpitations. Near syncope, no chest pain, no loss of consciousness, but just, felt kind of off. Now, I know your eye is immediately drawn to the T waves, right, which is normal, but you got to force yourself to do the 5 things. So what's the rate? Fast, slow, normal? Yeah, 300, 150, 175, so normal. Rhythm? Regular? Axis? Well, I say one looks actually negative to me, and AVF looks positive to me, so it's a right axis deviation, I think. Intervals? PR, QRS, QT. So I mean, the Q and the T is right at 2, so it's not more than 2, so that is not terribly prolonged. The PR looks normal. It's not a wide complex. It's not narrow. Oh, it is narrow complex.
How many boxes is the PR?
If I found a P like right on the line, it is, or right here, it's right at 0.2, right at 5. Here's another one. You might find, well, let's just say for the sake of discussion that it's 6 boxes, little boxes, and it's technically a first-degree AV block. Is that is that considered a life-threatening or dangerous block? Lots of people live with first-degree AV block. Now, if you do see a first-degree AV block, what's the first thing you should do? Make sure it's consistent, right? Because if that's a little bit long, and then the next one is longer, and the next one is dropped, right? Or every PR is a little bit different. One's normal, one's long, one's normal, one's... Okay.
With all the depressions, I was looking at posterior development as well.
Okay, yeah, that's not a bad idea at all. Especially in V1, 2, and 3, you see ST depression and T-wave inversions. It wouldn't be a bad thing to get a posterior 12 lead. Let's say for the sake of discussion that that doesn't show any elevation and you're okay. I mean, definitely the patterns are, now the patterns, you can go now to your inverted T's. You worry about ischemic changes in 2, 3, and AVF. Now, if you see ischemic changes in 2, 3 AVF, the first thing you should look for is look at what is next. It's very good. It's reciprocal, 1 AVL. Make sure that the real problem isn't subtle ST elevation in 1 AVL, which I don't see. Elevation in 1 AVL. Okay. Now, this is going to be tough, and I don't expect anyone to see this, but if you look really closely, can I convince you that there is an extra little blip at the terminal QRS? There's an extra squiggle there, okay? And if you look, and I just magnify it for you here, at the end of the QRS complex, there's an extra squiggle there. And that's not entirely normal. It's easy to kind of write that off, but in somebody who feels faint, lightheaded, dizzy, just not right, this is one of the other things you have to look for of the 5 that could be a cause for syncope. Anyone happen to know what the name of this wave is? It's almost like a J wave of Osborne. If this guy were hypothermic, like found outside in the snow, I would definitely consider that. But he wasn't. That's a good thought, though. This is actually characteristic of an epsilon wave.
Oh, yeah, that was Epsilon. Yeah.
So an epsilon wave is a small positive deflection buried in the terminal QRS complex. So a small positive blip that's buried at the end of your QRS complex. That epsilon wave is typical of ARVD, arrhythmogenic right ventricular dysplasia, or ARVD. So the name should tell you what ARVD is. So who wants to tell me what a right ventricular dysplasia means? What if you read this in one of the patients you're transporting or transferring from one hospital to another? It says, history of ARVD. What's happening there? So where is the problem? Very good. So let's start with the easy stuff. Right ventricle, okay? So dysplasia simply is an umbrella term for abnormal cells, basically, or abnormal development, okay? A dysplasia means the cellular makeup or the cellular structure of a tissue is dysplastic. It's changing. It's beyond normal, okay? What does arrhythmogenic mean? What is arrhythmia? An abnormal heart rhythm, right? So arrhythmogenic means it promotes or suppresses bad dysrhythmias. Promotes is arrhythmogenic, like a genesis, right? So an arrhythmogenic right ventricular dysplasia literally means a change in the tissue of the right ventricle that causes arrhythmias.
So like cardiomyopathy on the right side?
It is a form of a cardiomyopathy, which is an umbrella term for something that's bad with the heart. There's hundreds of cardiomyopathies, right? I mean, there's 4 basic classes, but yeah, that's another umbrella term. You know, when a doctor doesn't know why the heart is malfunctioning, they say, it's a cardiomyopathy. Right, exactly. I'm giving you all our secrets. Okay. So when you look at autopsy, what an ARVD patient's heart looks like at autopsy, this is what it looks like. So basically, what you're seeing here is the left ventricle with what looks like relatively normal myocardium. But where is the heart muscle on the right? I mean, you don't see a whole lot of muscle, right? That's because the muscle has been replaced with fibrous and fatty tissue. Does fibrous and fatty tissue contract as well? No, not nearly as well. And so the problem is that, unfortunately, this is the autopsy of a young basketball player that collapsed and did not make it. You see that in the outer walls of the right ventricle, and even some of the left posterior lateral walls, you see that it's almost entirely replaced by fatty tissue. So notice that there's not a whole lot of actual thinning of the wall itself. It's just replaced. It's replaced by fatty tissue. So when you see that small positive deflection that's buried in the QRS complex, it is a genetic problem, autosomal dominant inheritance typically. All that right ventricle gets replaced. You get a lot of ventricular dysrhythmias originating from the right ventricle. And when that happens, especially if it's VTAC or VF, they're going to pass out. Very often exercise related. A cardiac MRI will see it, will diagnose it. Really, the protective strategy will be an AICD. That's about all you can do, or a heart transplant. So given that heart transplants are very hard to come by, usually the first bridge therapy is going to be a defibrillator, an AICD placement. It's one of those things that you can, again, see, certainly in that particular patient, you would have had a propensity to transport because of all the T-wave weirdness that you saw, right? But if they had an otherwise relatively normal tracing and your eye didn't pick up that little blip, then you might mistakenly let them sign a refusal or encourage a refusal, which would be bad. Here's the other thing to consider, however, and that is that only about, even though this is considered a classic finding, classic means maybe 25, 30% of the people with ARVD have that epsilon wave. The rest don't. Okay. So take-home message is it's only helpful if it's there. It's only helpful if it's there. Only helpful if it's positive. All right. Case number 4, 51-year-old with lightheadedness and spells of passing out. Boy, what's up with all these people passing out? Here's his 12 lead. This one some of you may actually know because it's gotten a lot of press recently. But let's do our things. The rate, is it too fast or too slow? About right. 300, 150, 100-ish, so 99 some-ish. Yeah, so it's not too fast, not too slow. Rhythm. Regular. Axis. 1 is up, AVF is up, 2 thumbs up, normal axis. Intervals. Yeah, it's a smidge long. It's a smidge long. Remember that as the heart rate gets faster and faster, you really do have to then calculate what the corrected QTC is for rate. This is where it's helpful to look at the EKG's QTC, and as long as it's less than 450, 460, you're okay. There is a particular pattern, however, that looks odd. You may not know the name of it, but who can tell me which complex looks odd?
V2.
V2 looks odd. V1 looks odd. So this is one of the more important things that I really want to drive home for you today, which is what you should do as a paramedic is really, really, really know, just confidently, what does a normal tracing look like. You don't necessarily have to memorize 400 different variations. Just know what a normal 12 lead looks like, and if it ain't that, then something's not normal. So the fact that you may not know what the name of this syndrome is, but you could tell that V1 and V2 ain't right. To me, that's enough. That makes me feel confident knowing that if you are with this patient who had concerning symptoms that may be cardiac, and man, sir, I honestly don't know exactly what is here, but two of your leads look very abnormal, and you need to see a doctor because this could be very bad. That's all that the patient needs to hear from a licensed medical professional, that, hey, I need to go see a doctor. That may be enough, okay? So if I were to kind of blow that V1 and V2 up for you, you can look at it a little bit more closely. What is it about it that looks odd? Yeah, it kind of looks like one of those ski slopes, right? You go skiing down and jump off the ramp. You know, that little ski slope, ski jump looking thing. It looks odd. And interestingly enough, there are three types of abnormality. This is the most serious one. This is a type 1. Type 1 EKG showing that ski slope looking thing, typically in V1, 2, or 3. Type 2 is a little bit less common, but it has that characteristic saddle back. It looks like a horse's saddle from the side. And there's some ST elevation too. That would catch your eye, right? So it's got that little horse's saddle. Type 3 is the same thing, except there's no ST elevation. So you look here, you can see that there's that little scoop, that little horse's saddle looking thing, but there's no ST elevation. So that's really the only difference. But type 1 is considered the most serious one. If you see a type 2 or a type 3, you should definitely let the patient know that that is also a risk factor that needs to be investigated, and not next week. You need to go to the ER now and let the ER doc and cardiologist fight over what happens to you next. But it ain't normal, okay? So when you look at type 1, this is called Brugada sign, okay? Anyone at least heard of it now? Brugada, okay, so a couple, three of you have heard of it. This is Brugada sign. So Brugada sign, you have this coved ST segment, kind of looks like a ski jump, in more than one of V1, 2, or 3, followed by this negative T wave, which is that ski jump looking thing. And of the three, this is really the only one that's truly diagnostic. This is true Brugada sign. Now, when does it become Brugada syndrome? When you got clinical symptoms from it, okay? But they probably do, that's why you're there. Okay, so this is Brugada sign. Now, Brugada type 2 has that saddleback with ST elevation, like we said, and then Brugada type 3 is the same, but no ST elevation, so there it is. Interestingly enough, 3 brothers from Italy, all cardiologists, kind of studied this and developed this, so that's why it carries their name, the Brugada brothers. They said, you know what, back in 1992, they saw a cohort of people that all suddenly died, and they noticed something. They said, all of them have this weird-looking V1 and V2. Just like you just said, that looks odd. What is that? And so as they went back and looked at all these people, they found that almost all the patients were male, and they all had the same kind of clinical symptoms and the Brugada sign, what came to be called Brugada sign, and that together means Brugada syndrome. So what is that clinical criteria, you ask? I'm glad you asked. It is VF or VTAC, or a history of fainting spells or syncope. Like if someone says, you know what, I've fainted before, I've had these fainting spells, I don't know, but I'm always fine afterwards. That should raise a little red flag. If they have a family history of sudden cardiac death less than 45, or this saddleback tracing in any family member, that by itself, plus them having Brugada sign, is Brugada syndrome. Okay. Nocturnal agonal respirations is another one of those clinical criteria. This is why when we do sports physicals, we always ask the athletes, hey, have you ever had a family history of sudden cardiac death you can't explain, or sudden death less than 45, early age? These are all reasons to look really closely at their 12 lead to make sure they don't have any of this stuff. Type 1 is pretty easy to see because it's so abnormal. It just looks weird. Type 2 and 3, especially type 3, is very easy to miss because it doesn't just stand out. You have to be intentional about looking for it. So something else that was interesting, the Brugada brothers noticed that not only were they all male, almost all of them were of Southeast Asian descent. So it's so common that the Southeast Asian population had names for it, okay?
See you later.
Why are they going to pick on you like that?
They're not going to pick on you, sir.
Yeah, that's right. Don't pick on me. No. In Thailand, they call it lai tai, death during sleep. When in the Philippines, bangungut, which is to rise and moan in sleep. And in Japan, pokuri. And you have to say it like that too, pokuri.
Correct dialect in all three languages.
Thank you. Appreciate it. Appreciate it. I spent a lot of time practicing that. I love that one. That translation is sudden and unexpectedly ceased. Yeah, they sure did. They unexpectedly ceased. So the treatment for this is AICD placement. So when somebody comes in with Brugada syndrome, they go home with a AICD in their chest. Okay. You up for one last case? All right, case 5. 38-year-old female, palpitations, dizziness, pre-syncope, had a little bit of chest discomfort early in the day, but not now. Rate, 300, 175, 60. Not too fast, not too slow, about just right. Rhythm, regular. Axis, intervals. The intervals look fine. The PR, QRS, QT is fine. Patterns. T wave changes, ST depression, ST elevation, Brugada, Wellens, De Winter, anything? She says, in about 3 hours, I have a house full of company coming. Can I go? I'm fine now. No, I can't go? Well, paramedic, what are you basing that on?
It's just strange, she's got the Q wave and 2, 3.
Okay, so remember what I said? I said sometimes you may not know what's what, but you know normal and abnormal. So it is, what's not normal? You said?
Q wave.
Q. So do we normally see Q waves like that? No. Can you see a Q wave, and if you do, what is considered a normal Q? So normally we have said that there's significant Qs and insignificant Qs, right? Insignificant Qs are Q waves that are typically less than a third of the height of the QRS complex, right? If it's more than a third the height of the QRS complex, what does the machine usually say at the top? What it usually says is myocardial infarction, age indeterminate, right? That's what it usually says. I'm sure you've seen that all the time, and it's because the machine sees a Q wave. However, what makes this Q wave very distinct is that it has a very specific morphology. And this is not the same patient, this is a different patient. But what do you notice about this Q wave? Also very significant, not only in this case is it more than a third, but it looks incredibly sharp, for lack of a better term, like a dagger, like a dagger knife. Over here, again, this is also a different patient. Big Qs, very sharp, like a dagger. Very sharp Q waves. And what these are called is just that. These are called dagger waves. So dagger waves are septal Q waves. In the lateral, sometimes inferiorly, 2-3 AVF leads that are classic of a hypertrophied ventricular septum, typically. You usually also have, not always, but usually also have criteria for LVH, left ventricular hypertrophy. The reason why this is significant is that when you have somebody who's had lightheadedness, pre-syncope, or actual syncope, often in the case of exertion. So she told you she was doing what? Getting ready for a big party, right? Lots of guests. If she's anything like my wife getting ready for people coming, it's like get out of her way. Because
Very peaceful.
I page myself, so I have to leave. I'm kidding. Sort of.
All human are the same.
Run!
I gotta go blow the leaves off in the front lawn.
Right, I gotta go.
It's middle of summer.
But she is on, like she's a tornado moving through, doing stuff. And so she's probably exerting herself, running up and down, vacuuming and cleaning, cooking and all this other stuff. So exerting herself. And what happens is when the ventricle, the septal ventricle gets so hypertrophied for whatever reason, it can actually block the outflow tract. So here, the ventricle, look how thick that left ventricle muscle becomes. Remember we said that you can also get LVH on your EKG. What usually clues you into this person has left ventricular hypertrophy? What do the QRSs look like? They're off the chart, right? I mean, they're like running off the page. That's one where you might want to go to half standard to shorten some of those to get it all on the page. And you don't have to, but sometimes you might want to do that. And what happens is as the heart is pumping, if you can imagine, first of all, less blood is getting into the ventricle because it's so thick. And then as it squeezes, kind of look at what happens here. Think about what happens here as it's squeezing. If this is so thick that it actually touches, what's happening to the blood that's in here still? It gets trapped. You actually have LVOT, left ventricular outflow tract obstruction. Okay, LVOTO. And it is also genetic. It's a genetic failure of genes that encode for one of the 9 sarcomere proteins in the heart. So remember, sarcomere, just for your quick review, because I know you already memorized this at one point in time, but the sarcomere being the functional unit of a muscle, if one of those 9 sarcomere proteins are not coded correctly, they just hypertrophy and get dysplastic and get really, or hyperplastic, and they get really thick like that. And it's often undiagnosed until a significant cardiac event like syncope. It affects males and females of all races equally. So it is an equal opportunity killer, and it's called HOCM, hypertrophic obstructive cardiomyopathy. So as the left ventricular wall thickens and thickens, and the septum also thickens, as you can see here, you get a much smaller ventricular cavity, and that outflow tract through the aortic valve can get obstructed by the heart's own beating. And interestingly enough, we're going to talk about HOCM a little bit more when we talk about Impella and balloon pumps, why we do those. So really, it's medical management, often beta blockers to help kind of reduce the contractility, right? Because you don't want it to squeeze so hard that it chokes off its own outflow tract. Also, sometimes they have to increase the afterload, which sounds weird. Why would you increase afterload in hokum in some cases? Can you explain that? Because it seems backwards. Wouldn't you want to decrease preload?
Because there's not enough volume, eject it out, you're knocking on the diastolic, you won't be able to push back into the coronary arteries.
Oh, you're very, very close. You're very close. I'll give you a hint. It's kind of like CPAP for the heart. It's stenting open the LVO. So you stent open the LVO tract, the left ventricular outflow tract, by increasing afterload a little bit. That elastic recoil in the aorta is able to kind of keep, theoretically, the heart from squeezing in completely, like continuous positive pressure, essentially, is what it is. And so instead of choking off its own outflow, it kind of stents it open a little bit. Yeah, that doesn't make any sense until you think of the flow dynamics of what's happening to block the flow out. So the other thing is surgical management. So you can actually do a transaortic septal myomectomy. So they'll go in endovascularly through the aorta, and actually that piece of muscle that's squeezing its own supply off, its own outflow out, they'll cut that out so that it no longer causes that blockage. Kind of like when an ENT surgeon cures snoring by just cutting the soft palate out. That whole reason for snoring is gone. You just cut it out, right? So,
Will that show up on a 12 lead for anything? Like, because it's injured technically right after surgery?
that's a good question. I don't know how the 12 lead would change. I wonder if the dagger waves go away. That's a good question. I'll have to look that up. So, to recap, what are the 5 cannot miss things you have to intentionally look for in patients who faint, feel lightheaded, have palpitations, syncopies? Look for the delta wave. Look for long QT. Look for that epsilon wave. Look for a Brugada sign, type A or Brugada B or C. Look for those dagger waves, poke them. And I will say again, note, it's only helpful if it's present. But isn't that true of all 12 leads, right? Let's just take the normal, I have chest pain, I think I'm having a heart attack. Well, sir, your 12 lead hasn't really changed or it's non-diagnostic, so I guess you're not having a heart attack. Is that true? What percent of initial 12 leads in people actually having an MI are either normal or non-diagnostic or unchanged? You remember? I hear 39%. Any other guesses? I hear 40%, 54%. We are playing Price is Right rules. You cannot go over. 62? Okay, it's about 50%. So someone said 40 something. Whoever said 40, you win. Good. So yeah, basically it's like flip a coin, right? So a 12 lead EKG in chest pain is really only helpful if it's positive. If it's unchanged or non-diagnostic or even normal, you have to go by history. Remember, acute coronary syndrome is a clinical diagnosis. STEMI is a paper diagnosis. So people, especially new medics, which none of you are, I know, but new medics will get this confused. They'll say, well, the 12 lead is fine though, so they can't be having a heart attack. Wrong. The 12 lead is unchanged or non-diagnostic. This is why if you really, really, really think someone's having an MI, what do you have to do? Serial 12 leads, right? More than one. Yeah, frankly, it's malpractice not to get more than one if you think someone's really having a MI, yeah.
Like between 30 minutes to 2 hours before you can even see ST elevation when symptoms start?
I don't know that you can, it can definitely be that spread, yes. There's a wide range. Some people never develop a STEMI, right? That's why they are NSTEMIs. So, but you can never really tell. But I've caught STEMIs on the third or fourth tracing when I'm like, this person, I know they're having a heart attack. And you know, an hour later, I get another one, and now they're stemming out. That changes everything. So you got to get more than one. But anyway, for this, what we went over today, all these signs are only helpful if it's positive. If they have a concern, if they have a story that's really concerning for cardiogenic syncope, then even if you don't have one of these 5 things, they may not have dagger waves, but their echo, when they're admitted, may show that they actually have hokum and some outflow tract obstruction without dagger waves. Remember, only 25% of ARVD has epsilon waves. That means 75% don't. So, but these are all things, the reason why they're so important is because if they're there and you miss it, then it's there for all to see. Just like if the radiologist misses a fracture, it's there for all to see. So you don't want to miss it, okay? And your eye will only see what your brain knows. So just kind of keep that in mind and be very intentional.